The title that I was given is Why Stopping Treatment, and also When to Stop Treatment. And I added some other objectives for my talk to it, and it's when to change treatment, and also perhaps when to restart treatment after you stopped treatment. So many questions to answer, and I think I will be a bit in a repeat mode from previous talks this morning, but we all learned that repeating is good for remembrance, so please stay with me. So this will be my take-home messages. I think that we are discussing all morning that the treatment goals in AL amyloidosis are clear, but how to get there is not always that clear. Relapse setting treatment, so what to give in when situation, is not defined that well, and I think we definitely need better involved FLC testing. So, goals of treatment. I think deep hematological treatment and what it means in definition has been discussed extensively, and also the role of MRD, minimal residual disease negative testing, is also becoming more and more important, but we need more data, I think, on that in prospective trials. And at the moment, for most patients, that will mean a new bone marrow examination, but with mass spectrometry methods in blood-based, perhaps we can circumvent that need for a bone marrow examination. But the other goal that there is besides the deep hematological response, is the duration of that response. We need a very long duration. It's not clearly defined how long it must be. I think as long as possible. And we all have patients being in remission like 15 years, and that's of course excellent. But I think at a minimum we need a remission duration of more than 2 to 3 years, because also organ responses take time to occur, and that will in the end actually improve the quality of life of our patients. So why should we stop treatment? Some treatments do have a fixed duration, so it's not really a question why to stop, you have to stop. Autologous stem cell transplantation is a clear example. It's a one-hit treatment, it's very high dose chemo, you rescue with your own stem cells, and then the treatment has been done. But also bortezomib or Velcade are always in fixed duration treatments because of the side effects. If you prolong with Velcade treatment, the polyneuropathy that was just clearly explained by Professor Delforge is increasing, and that's a side effect that will not go away anymore after you developed it. So that's very important that it's a fixed duration treatment. But we also have treatments that can be given for many years, like the oral drugs, the IMiDs, lenalidomide and pomalidomide, but also daratumumab or Darzalex, the immune therapy, can be given for many years. So why stop? Why should we stop those treatments? I think I will give some reasons why we can do it. First of all is the biology of plasma cells. And in most patients, not all, but in many patients, the biology of plasma cells in AL amyloidosis is different from the biology in multiple myeloma patients. In AL amyloidosis patients, most plasma cells are slowly dividing, so not rapidly dividing cells. And they can also stay dormant, sleepy, not dividing at all, for many years. So if you continue treatment in those situations when the plasma cells, the cancer plasma cells are dormant, you are actually over-treating a patient and not giving effective treatment anymore. Also, side effects is a main reason to stop or change treatment, because a longer duration of treatment will mean more side effects and also more complications of your treatment. So, and I listed some, but peripheral neuropathy is there. Fevers, infections, especially pulmonary infections, but also infections, nose and throat infections. Diarrhea or constipation are important infections that will increase with longer duration, for example, of lenalidomide. And also, treatment means visits to the hospital. There have to be blood samples drawn. What are the side effects? Is the treatment still effective? So you're much more involved in the hospital, and perhaps you want to go away for several months. That's much more difficult when you're on an active treatment to do so. Another reason is that we don't have the data yet to demonstrate that continuous treatment, instead of stopping treatment, is improving the lives of our patients. And as we all know, we don't have many good prospective trials in AL amyloidosis, but I would also like to show you an example of a recently published study that we just published, and it's the Leuven 104 study. And that's a study which started many years ago, and we gave bortezomib induction therapies for 4 cycles, and after that a autologous stem cell transplantation. So this is for a selected group of patients fit enough to tolerate this therapy. And if you look at the bottom, the upper 2 lines, so the black and the blue lines, these are the survival curves of the 35 transplanted patients in this trial. And this is a 5-year survival curve, and which is excellent. But after the autologous stem cell transplantation, no further therapy was given. And if you now see the lines of another Leuven trial, that's the Dutch trial organization of 65, that's a trial that also started even before the 104, of course. And you can see in the red line, it's the overall survival curve. It's again induction therapy with bortezomib, autologous stem cell transplantation, but thereafter lenalidomide maintenance. But there you see the 5-year survival curve is much less. It's around 70%. Even lower, I think 65%, and much less than we see in AL amyloidosis patients. So this makes some arguments that lenalidomide maintenance is not necessary after autologous stem cell transplantation, while in myeloma it has been proven to increase overall survival. So it's different, and don't think because it's good in myeloma that we should do it also in AL amyloidosis. And another drug, but perhaps that's more theory, because we don't have the trials to demonstrate it. If you stop a treatment when it's still in effective stage, perhaps you can use that same drug again if for a retreatment when a relapse occurs. So in the end, you will have more treatment options for a relapsing disease instead of continuing a drug. Then the patient is progressing under that drug, and this drug will not be feasible anymore in the treatment of these patients because the plasma cells are resistant to this drug. So you have less development of resistant plasma cell clones. So I made some arguments for stopping treatment, but when should you stop treatment then? So first of all, when your goal is achieved. Goal 1 was deep hematological response. It's not with one measurement. Some presenters talked about reaching a plateau, and that means that serial 2 or perhaps 3 measurements confirm that your goal, a deep hematological response, is achieved, that we call it a plateau, and then you can stop a treatment when this response is, of course, CR or VGPR. But we also have some clinical trial data to help us. For example, daratumumab trials has been given for 6 months or up to 2 years. So we like to listen or follow those trials. So normally also with daratumumab we stop after 6 months or 2 years, depending perhaps also on your situation and the response that you achieved, and if you are in a relapsing situation or not. And also you should stop a treatment when side effects cannot be managed anymore. And again, Velcade, stop the treatment if the neuropathy is going too far, because the complaint will stay there and it will impact your quality of life later on. So also changing treatment has been achieved, discussed previously. So when should we change our treatment when a patient is being treated? First of all, goal is not achieved. Deep hematological response is not achieved. Again, sometimes difficult to state in one measurement, but with first-line treatment, you should not delay this decision too long, because we all know now that if a patient is only in PR after 5 cycles, this is not good and is decreasing the quality of life, but also the survival chances of our patients. And also change treatment when a side effect is so severe it cannot be managed with dose reductions anymore. You have to stop, but you have to think about adding another drug to treat the patients and to achieve this goal 1, a deep hematological response. And sometimes patients, when we start a treatment, we have to change something, and that can be very frightening is perhaps a strong word, but it can be very disturbing to patients, because if it's going all right now, if we change the treatment, but it's important to realize that we do have guidelines, international guidelines also, but every patient is unique. And sometimes we just learn how badly a patient is affected by the disease when we start the treatment. So it's very common that we change something in your treatment course. So don't be scared of that. That's very common. That's how we advocate to do it. And mostly we change something in the dosing, so lower the dose mostly, but also lower the frequency of a drug. And of course, we should change the treatment when the treatment is not effective. So we stop treatment, and then when should we restart treatment again? And ideally, we should think about the disease if you have a hematological relapse, or you're in complete remission, you have a hematological relapse, then your involved free light chain increases again. This involved free light chain is the cause of amyloid formation, and amyloid formation will lead to organ progression. And the clinical trials of the clinical data suggest that that can happen 6 to 14 months after your hematological relapse is occurring. But it can be very difficult sometimes to detect a hematological relapse. And we also don't know exactly when is this rise significant. When will it lead to amyloid formation and also then organ progression, and when not? It's not that easy. And the FLC, so the rise of the involved free light chain, we have some formal criteria that we use also in clinical studies. And one of them is when the involved free light chain doubles in its value, and we have an abnormal free light chain ratio. But perhaps we are a bit too soon, because this abnormal free light chain ratio can also happen due to the lower rate, for example, of the non-involved free light chain. So the ratio is quite tricky to follow sometimes. Another reason can be that your involved free light chain increases more than 50% and above 100 milligrams per liter, but perhaps then we are a bit too late with treating. So the formal criteria, I think, we should improve on those. And why is it sometimes difficult to detect a free light chain increase of the involved free light chain? And that is because the free light chain test, and this was also discussed previously, does not differentiate between the involved free light chain that forms the amyloid and your normal free light chains that we all have that are polyclonal. And I think also discussed that perhaps in the future mass spec can help us with that, because they really can detect the clonal, the involved free light chain, and perhaps also the amyloid assay that has also been discussed at the moment, only being developed for lambda, in the future can help us also with that. So that's one problem of the free light chain test. It doesn't tell you if it's the clonal or not the not clonal free light chain. But also, we have some normal conditions that can give rise to free light chains. For example, an infection, a cold, or an inflammation in your body. They will rise both, so the lambda and the kappa. But still, it can be difficult to detect a rise of the involved only. And also, very importantly, your kidney function, your kidney clearance, also involves the free light chain measurements in most tests. And what perhaps is not known is that we have several tests for measuring free light chains. And for example, in the Netherlands, half of the hospitals use the Siemens assay, you see that on the left, and the other half is using the binding site, and they are not interchangeable. So if I see a patient from a site that uses the Siemens assay, the results of the free light chains will be different. So that's very tricky as well. But the test from Serolite, the Serolite and the Siemens test, they claim that there is no influence of kidney function on your assay results, while the binding site free light and the Sebia assay state there is influence on kidney function. And especially, for example, in patients on dialysis, it's extremely difficult to assess free light chains. And here you see all the tests that we have at the moment, the current test. And it's important to realize that all the formal criteria that we have in myeloma, but also in AL amyloidosis, are established with the test from the binding site, the free light chain test. So that also means that all the other assays, which have different normal values as well, sometimes also different ratios, you cannot just use them in the formal criteria because they are not established that way. And also at the moment, the free light test from the binding site has some problems with the normalization to normal, especially the kappa free light chain is going above its normal value, and also the mean of the ratio is just, it's going upwards, and we published about that some time ago. So with the standard free light chain test that we have, there are some technical problems at the moment, and we hope we can solve this also in the future. Then the second question, so we have established in hematological relapse. When is it significant? When will it affect your patient? And this model is, I think, mostly developed by the Groningen, so the Amyloid Center in the Netherlands, and it's the SYNC model. And it states that you have some amyloid formation, that's the tap, and some drips of free light chain are going into the sink. So that's A, it's going into the sink. C, and that means that's your amyloid load in your body. But there is also some amyloid degradation. So we have cells in our body that can eat up or lower the amyloid in your body, but it's going extremely slow. But there's B, there is some amyloid degradation as well. So when is the new amyloid formation in equilibrium, so how do you say it? Well, in the same way as the breakdown. So when is that not affecting your patients, but when is the amyloid formation more than the breakdown, and that will lead to organ progression? And so when is that? Is that the same for every patient? Does it have to be above the FLC above 100, or what I stated before? We actually don't know anything about this, and we actually also don't know if this model is the right model. So we also don't know the answer to this question at the moment. So back to my take-home messages. I think the treatment goals are clear. How to get there when treatment is not going according to plan, which is quite common in AL patients, is not that clear. Also, relapse setting is also not clear when to give what. We don't have formal studies for this, and we definitely need better involved free light chain testing in the future. Or actually, we do need it now, but it's not here yet. So in that sense, it's very important that you have experience. So it has not been talked about, but in Europe we have expert centers. They are all aligned in EuroBloodNet, and sometimes also some other expert centers that we have, because AL amyloidosis is not a disease that can be diagnosed and treated by every hospital there is. So experience is key to understand all these processes that are going on in patients. And with that, I would like to thank you for attention and give you the email address of our expertise center in Utrecht, and hope for many questions. Thank you.